Tinea Versicolor. Definition. Tinea versicolor, also called Pityriasis versicolor, is a superficial fungal infection of the stratum corneum that results in altered pigment in the epidermis. Clinically, the lesions appear as finely scaling patches, which, as the name, versicolor, implies, can be pink, tan, brown, or white. Of these, white is the most common. Tinea versicolor, hypopigmented patches. Tinea versicolor, pink, tan patches. Incidence. Tinea versicolor is a common disease, affecting nearly 1% of the general population. The incidence is higher in tropical climates. Any age group may be affected, but the disease is most common in young adults. Immunosuppression, including that from systemic corticosteroids, either endogenous or exogenous, can be a predisposing factor, but most patients are healthy. History. Tinea versicolor is occasionally associated with mild pruritus, but more often it is asymptomatic. Most patients seek medical attention because of its cosmetic appearance. Because the affected areas do not tan, the patient often first becomes aware of the condition after sun exposure. The surrounding normal skin tans, providing a contrast to the white spots. During the winter months and in persons with darker complexions, the lesions appear more deeply pigmented than the normal skin. Tinea versicolor, darker brown patches. Physical examination. The usual lesion is a round, hypopigmented, slightly scaling patch. It often starts as multiple small follicular macules, which subsequently become confluent. The scale is usually subtle and sometimes appreciated only with gentle scraping of the skin, which reveals a fine, crumbly scale. If a Wood's light examination is performed, the lesions will appear hypopigmented but not chalk white, as in vitiligo. With Wood's light examination, sometimes the scale fluoresces pale yellow or orange, but this finding is not universal and should not be relied on for diagnosis. The usual distribution for tinea versicolor is the neck, trunk, and upper arms, that is, the distribution of a short-sleeved turtleneck sweater. Distal extremity involvement is uncommon, except in tropical climates. Facial involvement is more common in people of African descent, particularly in children. Differential diagnosis. In adults, the white spots of tinea versicolor are most often misdiagnosed as vitiligo. In vitiligo, the absence of scale and complete depigmentation are distinguishing factors from tinea versicolor. Tinea versicolor appearing as pink or tan scaling patches on the chest may be misdiagnosed as seborrheic dermatitis. The distribution of seborrheic dermatitis involves the hairline, eyebrows, nasolabial folds, and middle chest. Laboratory examination. The organism cannot be grown on routine fungal culture, therefore the diagnosis rests with the KOH examination. Examination of the scale with a KOH preparation reveals short hyphae, which are often mixed with spores, giving the appearance of spaghetti, hyphae, and meatballs, spores. Biopsy, seldom performed, shows abundant fungal organisms in a hyperkeratotic stratum corneum. KOH preparation of tinea versicolor, diagnostic, spaghetti, short hyphae, and meatballs, spores. Therapy. Topical selenium sulfide, zinc pyrithione, head and shoulders, and ketoconazole, nizoral, shampoos are commonly used as body washes for the affected skin. These agents are effective, easy to apply to a widespread area, and relatively inexpensive. Topical imidazole antifungal creams are effective against the organism, but this approach is expensive when the eruption is widespread, which it often is. Terbinafine, Lamisil, spray is also effective but expensive. Oral fluconazole, diflucan, is the simplest and most effective therapy. In most adult patients, the fungus is eradicated with a single 200 mg dose, which may be repeated in 2 weeks. Efficacy is enhanced if the patient works up a sweat 2 hours after ingesting the fluconazole, thereby delivering the drug, which is concentrated in sweat, to the stratum corneum. For patients with recurrent disease, this regimen can be repeated every 3 months for 1 year. Therapy for tinea versicolor. Initial Lather selenium sulfide, zinc pyrithione, or ketoconazole shampoo in a turtleneck sweater distribution, preferably with a mesh puff. Rinse after 10 minutes. Repeat this for 3 days in a row, then once weekly for 4 weeks, then once monthly to prevent recurrence. Alternatively, can use it daily for 1 to 4 weeks. Apply over-the-counter terbinafine, Lamisil, cream daily if just a few spots. Alternative: fluconazole, diflucan. 1 200 mg tablet repeated again in 1 to 2 weeks. Course and complications. The fungus is killed rapidly with therapy, but it takes 1 to 2 months or much longer for the pigmentation to return to its normal color. It is important to explain this so that the patient will not view the treatment as a failure. After topical therapy, the recurrence rate is more than 50%, but this rate can be reduced to less than 15% with a monthly retreatment program using any of the recommended treatment shampoos. Note: after the initial therapy, it takes months for the white spots to regain pigment. Pathogenesis. Tinea Versicolor is caused by infection with the fungus Malassezia species, globosa, sympodialis, and furfur. This organism is frequently present in its yeast form as a colonizer of normal skin. In Tinea Versicolor, the spores proliferate in the outer layers of the stratum corneum, often beginning in the areas of follicular openings. When the spore forms are transformed into hyphae, infection occurs as the hyphal structures invade more deeply into the stratum corneum, but they do not penetrate the viable epidermis. They cause thickening and disruption of the stratum corneum, expressed clinically as a fine scale. Fungal enzymes act on surface lipids and produce dicarboxylic acids that diffuse into the epidermis. These acids inhibit tyrosinase, the enzyme in melanocytes that is responsible for melanin production. Not all patients exposed to this ubiquitous organism develop an infection. In fact, conjugal cases are uncommon. Some individuals may be more susceptible by virtue of a genetic predisposition, the nature of which is not known.
Clinical case. A 24-year-old man presents with a 4-month history of multiple asymptomatic hypopigmented patches on his upper back, shoulders, and chest. He reports that the lesions become more noticeable after sun exposure during the summer. Mild itching occurs occasionally, especially after sweating. He has no history of autoimmune disease or atopy. On physical examination, there are multiple well-defined hypopigmented and light brown macules with fine, browny scaling over the upper trunk. Gentle scraping of the lesions accentuates the scaling, evoked scale sign. Examination under a Woods lamp reveals yellowish-golden fluorescence, and potassium hydroxide, KOH, microscopy demonstrates short hyphae and clusters of round spores, spaghetti and meatballs appearance. What is the most likely diagnosis? A. Tinea Versicolor. B. Vitiligo. C. Seborrheic dermatitis. D. Pityriasis alba. E. Progressive macular hypomelanosis. Correct answer, A. Tinea Versicolor. A. Tinea Versicolor. Caused by Malassezia species. Hyper, or erythematous macules with fine scaling. Common on the chest, back, shoulders, and neck. More noticeable after tanning. Positive KOH, spaghetti and meatballs. Woods lamp, yellowish or yellow-green fluorescence. B. Vitiligo. Well-demarcated chalk-white depigmented macules. No scaling. Woods lamp shows bright blue-white accentuation. KOH is negative. C. Seborrheic dermatitis. Erythematous plaques with greasy yellow scales. Commonly affects the scalp, eyebrows, nasolabial folds, ears, and central chest. Not associated with hypopigmented macules or positive KOH. D. Pityriasis alba. Common in children with atopic dermatitis. Ill-defined hypopigmented patches with minimal fine scale. Usually affects the face rather than the trunk. KOH is negative. E. Progressive macular hypomelanosis. Symmetric, non-scaly hypopigmented macules on the trunk. No inflammation or scaling. KOH is negative. Thought to be associated with Cutibacterium acnes. Key learning point. The combination of hypopigmented macules on the upper trunk, fine Branny scale, positive evoked scale sign, Wood's lamp yellowish fluorescence, and KOH showing spaghetti and meatballs is diagnostic of Tinea Versicolor. The absence of scaling strongly favors diagnoses such as vitiligo or progressive macular hypomelanosis rather than Tinea Versicolor.